Good evening, everyone, and thank you for joining us. My name is Carver. I am a clinical application specialist here at Oculus. Welcome to tonight's clinical webcast, My Cold Start, featuring the OCULUS Pentacam AXL Wave. A couple of housekeeping items. You have a text box on your GoToWebinar screen where you can enter in questions. Enter in your questions at any time, and we will discuss them at the end of tonight's webcast. Our speaker tonight is Dr. Ariel Cerenzie. Dr. Ariel Cerenzie is a specialty lens and myopia management enthusiast. Her passion derived from witnessing the profound impact of specialty contact lenses on improving the current and future lives of patients. She cold started a practice called Charlotte Contact Lens Institute to focus solely on this type of care. Dr. Cerenzie attended optometry school at the University of Houston College of Optometry and completed a cornea and contact lens residency at the University of Missouri St. Louis College of Optometry. She is a fellow of the American Academy of Optometry and the Scleral Lens Education Society and is a member of the American Academy of Orthokeratology and Myopic Control. Dr. Cerenzie, I look forward to your presentation. Take it away.
All right, thank you, Carver. And thank you to Oculus for allowing me to present on this topic. So as Carver mentioned, I cold started a specialty contact lens only practice called the Charlotte Contact Lens Institute. The Oculus Pentacam AXL Wave really has been my shining star for so many reasons. The first was being able to market my practice. Like, hey, I have the best of the best equipment at this practice. And the efficiency of my practice, that was huge for me. Being sure that I was providing the best quality of not only care in monitoring whatever conditions I'm taking care of, but also the best quality lens designs that I could do. And I could go on and on, but we're going to talk about it in the presentation. So, you know, if you're attending this webinar, listening to this webinar, you've probably fit a scleral lens at some point in your life. And I want you to think about that first patient that you put scleral lenses on. It probably was a really emotional experience for them. And that's really what gets you hooked, right? Is those patients that you just change their life. So this was a patient I had a couple of months ago, and you know, you get to experience these tears of joy and disbelief, happiness, and then you're like, oh man, I am hooked. This is awesome. You know, what other profession do we have where we have the ability to make a profound impact on somebody's life like this? I just can't think of any other profession that can do that. You know, my husband's a business guy and owns properties, and he's like, yeah, I make people cry because I increase their rent. So I feel like we're very lucky to be in this profession and have the opportunity to make an impact like this. A little bit of background on where I started. I went to the University of Houston, as Carver mentioned. I did a cornea and contact lens residency. Really was motivated to do this residency by Dr. Clark Newman. I did a rotation my 4th year at his office and was exposed to specialty contact lenses for the first time. And it was really from that rotation that I was like, I have to do this. This is my passion. And I was diagnosed with keratoconus in optometry school. It's mild. So that further drove my passion once I was fit into scleral lenses and saw the pretty drastic improvement that it provided on my vision. So I did my cornea and contact lens residency with Dr. Julie DeKinder and Dr. Ed Bennett. Julie is still my woman crush to this day. I really appreciated everything that I learned during this residency. And a lot of folks ask, you know, well, do I have to have a residency to get into this specialty? And I would say it was very helpful for me to kind of fast track my education, but you absolutely do not need to. I know so many amazing specialty lens docs that did on the job training and got paid a lot better than I did their first year out of school. So after finishing that residency, I went into a private practice setting and brought that specialty to that private practice. So I was doing, comprehensive care sprinkled in with specialty lens care. At some point during that time, we had Sophie, our oldest little girl, who's going to turn 3 soon. And then Adeline, our second little girl, about 18 months later. So probably about, I was probably about 5 months pregnant. And I was in the kitchen with my husband one morning before I was headed to work. And I told him, I said, I really would love to start my own practice, but I just don't think that I can do it. And he looked at me and he said, well, why do you not think that you can do it? And I said, well, I don't really, I don't know business. I didn't learn any business in optometry school. Really, an optical really intimidates me. I don't know how the heck to do anything with glasses. I don't know the first thing about filing for insurance. And he said, well, why don't you just start a practice without an optical and without insurance? And I was like, starting an optometry practice without an optical, that doesn't sound right. But then I said, heck with it. I'm just gonna do it. I'm just gonna start a practice, do what I love to do, and not do what I do not love to do. So then the Charlotte Contact Lens Institute was born 2 months after Adeline was born. And then we have another baby boy along the way, and we are done. I'm done being pregnant. I feel like I've been pregnant forever. So that was just kind of our journey of starting this practice. So the dream was to not have to take insurance, not have an optical, and I wanted the best technology that was available to be able to offer to my patients. I felt like that was essential, and hence why I bought the Pentacam AXL Wave. And it was very important to me that the practice felt very welcoming to patients. Having the condition myself, I know it can involve a lot of, anxiety when you go to the doctor and you have this ever-changing vision, this ever-changing prescription. So I just wanted to feel very calm to people. And then, like I said, my concerns were, just running a business in general, but also reliance on referrals. In Charlotte, our area is a little bit unique in that we don't really have any, aside from 3 offices that are private practice ophthalmologists. The other entities where the corneal specialists are these large, almost like a hospital-like setting, where they really kept all of their specialty lenses in-house. One of them had a specialty lens fitter that had been there for 20 years, and she's amazing at what she does. So they obviously were keeping their patients, and then the other hospital had technicians that were fitting their lenses, and so it was very difficult to get referrals when I was at the private practice previously. So I was very nervous about being able to have a patient base with that in mind. So we'll talk about how we built the referral system, and now I went from thinking I would have just a few referral resources to right now I have over 100. I think last I checked, I have about 115 doctors that have referred to the practice so far. So I've come a long way from what I thought that I would. So first things first was to find a space. So what's pretty cool about this practice style is I didn't need to have a lot of real estate, which was nice. So I found an office space where I found a suite that was about 900 square feet. My pen got moved, but it's just that practice is just right below the Barclay Downs, just South Charlotte. So pretty central location, which is nice. So this is what my building or my lobby looked like before. So we ripped out all of this horrible carpet. That's baby Adeline and the Duna there in the stroller. She came with us so I could nurse in between all of the building furniture and stuff. That was a fun experience. That little nook in the bottom right is an area that I made into a little kids area eventually. This was what was going to become my exam room. So these are our before pictures, and then this is after. So this was that same room that we looked at before, made into one of my favorite rooms, the exam room where all the magic happens. So I have a little consult area where I share patients' images on that large TV there. So we'll look at that. I have another small screen next to the patient, so they're able to view all of the images that we do during their exam encounter. This is our lobby area. You can see the before and after picture there. And then this is my special testing room where I have an OCT that does anterior segment imaging with a 19mm cord. It's very nice to be able to see the lens from lens edge to lens edge. And then, of course, I have my Pentacam AXL Wave, my shining star right in the center of that room. Then behind that, I have like my insertion and removal training table. So again, this is my exam room. We're going to kind of come to the corner here. I find that when this is such a simple investment to invest into a TV. It's amazing how cheap these things are now, but when you can show patients their eyes with something as simple as anterior segment imaging, they are just so in awe about learning about their eyes, and they should be educated on their eyes. So I always show them their Pentacam images when they come in. I explain their corneal condition, why they see the way that they see. We go over anterior segment photography as well. And being a cash pay practice, patients really have a little bit more like buy-in when they have this confidence of the level of technology that you're offering them, and the fact that you're taking this time to explain their eye health, that you're an expert in this. And so I always find that after the diagnostic lens fitting, showing them how great they're going to see the world with their over refraction, and then having this educational experience with them, I very rarely have folks that do not move forward. So let's talk about my shining star here. So, starting this practice, I wanted to have I wanted this instrument, and I knew I was not going to start patient care until I had it. And I didn't care if it was going to take me longer to get it. I wasn't going to start seeing patients until I had it. And it does so many things in one. It does the objective refraction, so I didn't need to get an auto refractor, which was really nice. It does wavefront aberrometry. You may think, well, why would I need that? I will show you a couple of examples in some patient cases that I had later where it was really helpful for me to have that, and it really saved me a lot of time of troubleshooting patients' vision, because I knew exactly what was going on with their aberrations before they told me how poorly they were seeing out of a scleral lens. Optical biometry. This is essential to me in doing myopia control and myopia management, is to be able to know exactly how long their eye is, because it tells you a lot of things beyond what refraction does, especially with things like orthokeratology, where their refraction may be a little bit different depending on what time of the day that you see them. So with this tool, I like to demonstrate to parents where their child's axial length lies on normal growth charts, because parents are very accustomed to seeing that at pediatrician offices. Now, every time that I take one of our kids to the pediatrician, I'm eager to see where they fall on that growth chart. And our youngest right now is a little peanut, and our oldest was always like off the charts, and it drives me crazy that she's not, where I think that she should be. But when you can demonstrate that to patients, it really is great for educational purposes. Also, other instances where optical biometry has been really beneficial to have is I've had a couple of kids that are, minus 350s, yet their axial length is like 26, and once you get past that length of high axial myopia, that's when we really start to worry about ocular disease later in life. So for those types of patients, even though their myopia is not, what I would call high myopia yet, I'm going to be more aggressive with their myopia management treatment, knowing that they have higher axial myopia. And then, of course, we know we have our Scheimpflug tomography, and this really is the standard of care for keratoconic patients. When I was at my private practice, if I had a keratoconic patient, I wanted them to see their corneal ophthalmologist to have Pentacam images done, because we weren't lucky enough to have one at the practice, because I wanted to know when that patient was progressing at the earliest signs. And Scheimpflug tomography allows us to do that by having the ability to know the changes that are happening to the posterior cornea curvature and the thickness. Also knowing whether or not patients are going to be good cross-linking candidates. So this is absolutely essential for me in managing the amount of keratoconic patients that I have. And then, of course, the CSP software, cornea scleral profile. This is a game changer for me. One is that I just have to do one image. Now, I do want to say that I am the only person physically at my practice. I have a virtual assistant that she's amazing. She does pretty much everything remotely for me. But I'm the only one that's physically there, and I'm able to get great images for my patients. Basically, what I ask them to do is I will often put proparacaine in some of these patients' eyes that are really dry. I see a lot of dry eye patients that are fit into sclerals. But if they don't need it, great. I try not to. But sometimes it does make the acquisition easier. But I'll just have them kind of reach around the bar where their chin rest is. I'll have them hold their lower lid. I'll reach around and hold their upper. And most of the time, I'm able to get all of the data that I need in one. But if you need to take multiple scans, like say I wanted to get that little bit piece, that little sliver that I missed at the top, then you can, just hold their top lid and get that, and it'll stitch it together. There have been instances that if I have a patient with really tight eyelids, or just kind of a small aperture, I have lid speculums in my office, and I put those on them. I, of course, make sure that it's not, pressing on the sclera, so I'm not inducing any curvature changes of the sclera from that speculum. But just as long as I'm lubricating their eyes well and making sure I'm not drying out their corneas from being open constantly, I'm always able to get very good data. And I could go on and on about the cornea profile software and all the advantages of it, but a big advantage is that you don't have to instill fluorescein. You don't have to ensure that you have the most lubricated eye. I'm just doing that for comfort for people. And it's agnostic to a lot of these freeform designs that are out there. So a lot of designs, scleral lens designs, ortho-K designs, gas permeable lenses can use this data to make a very custom lens versus other scleral profilometry equipment that you have to choose a specific type of lenses that they are compatible with. So that's another really nice feature that was very important to me. And then, of course, I fit so many different lenses. I feel like it's very important to have a large portfolio, but gosh, I really do love my Wave software, just being able to go in and make all of these tinkering with it. And you can make this as involved or uninvolved as you really want, but you can see in this little control panel that was made with a more recent update, you can just go into modification, change your alignment angle, limbal clearance, central clearance, and you can choose the number of microns that you change it by. They made it very, very easy. Also, I love this lens for their multifocal optics, and I'm going to knock on wood, but I've had really great success with multifocals because these center so well because they're made for their eyes. And I don't know that I had great success with multifocals, scleral lenses before using this. So this was really cool. This few months before the practice opened, we were in Germany. My mom is from Germany. And I looked up the Oculus headquarters in Wetzlar, and maybe made some Germans cringe a little bit by pronouncing that. I think I pronounced it right. But I contacted my rep at the time, Joe Nemeth, and said, hey, I'm in the area. Any chance that I could just swing by and maybe meet a couple of people or just kind of see the facility? And they really welcomed me with open arms. That's David Kern there on the left. And then Christian, the CEO of Oculus, gave me this personal tour throughout the entire facility. And gosh, it was amazing, the level of technology and just thinking about all of the little tiny pieces that go into making each of these instruments. I mean, it was incredible to be able to see it, and I'm really thankful I had the opportunity to. So I speak a little bit of German, and I was very pregnant at that time. So I was trying to, I was like, hey, please, can I get a Pentacam like as quick as possible? But it was really cool to be able to meet them and see the facility. Kind of a fun fact, I'm going to start this over, is this is the biggest eye chart in the world. So I don't remember how many kilometers you have to go, but they have this little sign where you can test your acuity from however kilometers it is away. So that's pretty cool. It's on the side of their building. So, all right, let's go ahead and start talking about building the patient base of this practice. The first thing that I did was I marketed a grand opening. I drove about 300 miles over the course of like a month, going to every single optometry practice in the Charlotte metro area and hand delivering a little baggies with a little bottle of wine, and then inviting them to like a wine tasting for the grand opening that we had. Which I think, it would catch my attention if somebody gave me some wine. So I was like, I feel like a lot of people love wine out there. Why not? Let's do it. But in there, I had a little blurb about our practice. And one of the things that I featured was the Pentacam AXL Wave. And the fact that I would be able to take great care of their patients because I have some of the best technology. And at the time, I was one of the few optometry practices in the country that had this. So that was really kind of the thing that I used to market this practice, that I'm in business. I was going to take the best care of patients possible because I have the Pentacam AXL Wave. When I had the opportunity to talk to some of these doctors, I asked, would you like some brochures to provide to some of your patients? So offered them some brochures, and patient-facing wise, I also marketed this technology. And I basically say to patients, this lens is entirely custom to you. We're taking over 240,000 data points from the eye to create your lens. You've probably never had a lens like this before. So not only was I using this to market to referring doctors, but also to patients to show them that this level of lens that you're getting is very different from what you've had in the past. I kind of would sprinkle marketing things to doctors through mailers, and this is another form that I have where basically I talked about all the things that my Pentacam does, the scleral topography, the corneal tomography, how I could use this for determining need for corneal cross-linking. Kind of like in my instance where I was in a private practice and I didn't have access to that technology, I would love to be able to refer it to a fellow doctor down the street that, would take good care of them, spend some time to educate them on the imaging. Talked about, how I can use it to design freeform orthokeratology and gas permeable lenses, very custom lenses, aberrometry, biometry for those axial length measurements. So again, another centerpiece of my marketing efforts. And then I'll also send newsletters to local doctors about some of the fun success stories that we've had at our practice and how the technology that we have at our practice allowed us to have these success stories. Then lastly, I think it's very important to show appreciation to these referral resources. So I send them a little cup when they first refer to us, along with a thanks a latte, thank you note, and a Starbucks gift card. And I think it's really important to continually communicate with these doctors what's going on with their patients. And yes, I am going to send them back to you, or no, you said you did not want this patient back. You said that they were a train wreck, so I will keep them and you will never see this person again. So that communication is very important. And typically I'm sending those doctors imaging of what we did that day. So let's talk about how I've used the Pentacam AXL Wave in my practice to help me be more efficient and just be able to do things in a quicker amount of time than I would be able to do if I was even able to do it with more of a conventional fitting philosophy. So I meant to, actually, I asked my virtual assistant today, her name's Pia, to take a screen record of a patient that I had today so I could just show you how quick this process is. And I did it on my last patient of the day, and technology was technology on her end for a screen record. So I didn't get it, which I was really bummed, but essentially, let me start this video over. You just go to new full sequence and it pulls up everything you need here. You have your aberrometry. So you quickly get the aberrometry, tell your patient this is, you should be seeing a hot air balloon. And then it'll give us our aberrometry data. And then we can quickly go to axial length, and you would just choose beforehand what the status of their intraocular lens is or isn't. And then our CSP Pro at the end. And you can toggle this little area down here to just do a corneal tomography or CSP Pro. So it really is very, very fast. And like I said, I'm the only one in this office. It was important to me that it was fast because I have other things to do, so I didn't want acquiring an image to be the bulk of a patient's time with me. So this is what the aberrometry data looks like when you are finished acquiring the scan. So for this particular patient, you can see over here that this is the objective auto refraction that we have. at the 3 millimeter optical zone. And then it also tells you the level of higher order aberrations this patient has and lower order aberrations. So remember, lower order aberrations are those aberrations that we can correct with the which is better 1 or 2, and higher order aberrations are everything else. So I forget what the exact number is, but I believe the upper limit threshold for normal eyes with coma is like 0.355, and then anything above that is considered abnormal. That was one paper I read. I'm sure different papers will say different things, but this was a keratoconic patient. So as expected, they had 0.639 coma aberrations, so pretty high. And what I want you to notice is that these aberrations were in the negative direction. So what does that mean? I mean, typically it just kind of tells you the direction of that like flare and that smearing effect they have from coma. And that's something that I've recently learned is very important to pay attention to. I first heard this from Dr. Christine Sint, and it just really, I've seen it a lot now. Because sometimes, so these patients are very used to these aberrations of this kind of like smearing effect in one particular direction, and their brains have neuroadapted to that. Well, when I put this patient into a scleral lens, her aberrations, her coma went in the entirely different direction. They improved, but they were still very high, 0.423. So I just kind of wanted to see what her experience was like in these. So I went ahead and so this is the now the aberrometry over a scleral lens. So this is the objective refraction that data from the over the lens. So I went into the exam room knowing it probably wasn't going to go well, and I just quickly dialed in a +3, -175 at axis 160. And she was like, oh God, that is double. I can't see anything. And she was reading 2025, whereas before she was much worse, but yet she couldn't see anything. It was double. Well, these patients can't handle when you switch over their that smearing effect. And it is very challenging for them to adapt to something like this. So I knew that a soft lens would be a better option for her. And we have lenses for keratoconic patients that are soft. So she did much better in that versus a scleral lens. So I saved a lot of time by knowing this, by really scratching my head and being like, what do you mean you can't see? You're 2025. We made you see so much better. What are you talking about? And I think a lot of you probably had those. I've had them and had no idea what was going on before I learned this. But that's what's going on. They're not crazy. I mean, some of them are, but like I can say that I have keratoconus. I'm part of them. So this was another patient who came to see me. He had, what we call like a proud graft in his right eye, keratoconic. In the left, you can see his right eye really, really steep, Kmax of 105, and this is what his graft looks like from the side. When I looked at his higher order aberrations, this is uncorrected 0.921. So when I put a scleral lens on him. So this is just to orient us. This is uncorrected over here. This is those numbers that we just went through of 0.921, higher order aberration, and then coma, we have about a 0.8. And I pay attention to coma because that's really the most common higher order aberration that we see in our cones. But of course, they're affected by others. Well, he actually had a lens that he presented with that he was pretty happy with, but notice that his coma is still about a 0.294, so within the normal limits. But I wondered, what if I put him into a lens that has some built-in, eccentricity? Would that help? We know that some of these designs, these optical designs, can help to improve coma. So I just was like, hey, you know what? Let's try some different technology, see how you do. So I put a diagnostic lens on him. That's why it has more of a refraction than his presenting lens, which was much more accurate vision-wise. So I dialed in this refraction for him, refined it some, and he was like, wow, I thought I saw clear before, but this is incredibly sharp. And he told me how much better his nighttime vision was, how much he feels so much safer driving at night. And I remember he had no complaints before, but if I having this technology, I was able to make a difference in his life with the knowledge of what I was able to see with his aberrations. Anytime I'm going to do tomography on somebody, I always look at these four maps. It gives us a good insight into a lot of different things. The axial curvature of the front of their eye, the back of their eye, what the elevation is looking like, and their corneal thickness. So not only are these like the curvatures and the elevations important for gas permeable lens fittings or specialty contact lens fittings, but also looking at the thickness of the cornea, knowing, okay, this patient is very, very thin. Not this one, but some patients I have a corneal thickness of 200 microns, and I'm probably going to design their lens a little bit differently where it's very easy for them to take off. I want to really counsel them on any potential high drops, stressing, do not rub your eyes, whatever you do. Also, this is very important to look at when you have our pediatric patients. We want to make sure that there are no signs of keratoconus or ectasia in these patients before we put them in something like orthokeratology, because gosh, that would be terrible if this kid had orthokeratology and we didn't catch it before we put them in ortho-K. The progression display, when I have patients come in, I'm checking this display to see if they are potentially progressing. This is the way to be able to detect the earliest possible progression. So I only have 2 data points on this guy. I just saw him yesterday, and I told him, I said, it looks like you've had progression. He's had epi-on cross-linking 13 years ago. So he was very surprised by that, but I sent him to the corneal specialist that he had a long history of and had multiple Pentacam images of, and sure enough, he did have progression, and he's going to be going through a FDA-approved epi-off cross-linking now. So, and then of course the CSP report, just love this thing. I smile every time I look at it. So this particular patient, they had a very elevated pinguecula. So we can see when we look nasally how elevated this area is, and you can kind of see it on these little bumps on the CSP, the profile scans, just how elevated that bump is. Would be pretty challenging to fit a conventional lens on there. Get my toric peripheral curves, make sure that it lines up perfectly so I can add, whatever technology I need to add to avoid or vault over that conj obstacle. So this is the lens that he came in with, and of course his complaint was that his eyes get really red and painful. This was the first lens that I designed based off of his corneal scleral topography. So I talk about a slam dunk. I mean, that saved me a lot of chair time, and what a difference that made to this patient. There are some instances where you just cannot acquire the best scans possible, but this instrument allows you to get the best that you possibly can. And like for this particular patient, you can kind of see maybe that I had a lid speculum on him. So, just the fact that we still have this like stitching capability is very important, but know that your scans will always not look like perfection. So this is just demonstrating. This is a patient that had just high refractive astigmatism, and it really went out to the sclera as well. We had witherul astigmatism of the sclera. And so another thing I want to take note of is that every quadrant is a little bit different. So if I wanted to optimally fit these lenses for this patient, I would need to have like a quadrant specific lens for best fitting possibility. And if you don't, you know that we can get decentered lenses. And I just put a few points that I just threw out. But when you have decentered lenses, they can be very uncomfortable for patients. You can get impingement in areas from that falling of the weight of the lens. You get things like fogging, which we know is a pain in the butt. You can get SIL that's induced from just that tear meniscus behind the lens, things like conj prolapse. This is just a sample of some of the things that you can get from a decentered lens, but it's not fun to deal with these. So this is a patient that was complaining of having fogging after just about 3 hours. Well, it's very clear the sodium fluorescein is leaking through the top here and through the bottom. So these edges are too loose, and we needed to align them with the sclera a little bit better. And that unfortunately was on both eyes. So I had some work to do on this one. And we know that from data from all of these amazing doctors, Dr. Greg Denayer really led the way on scleral toricity studies. The further out from the limbus we get, the more scleral toricity that we have. And I really encourage you to take a look at some of this data if you haven't, but even, at just a 16 millimeter diameter, we have pretty big differences in the vertical meridian versus the horizontal meridian, where we have elevation changes, and it can be very asymmetric. And in his studies where they looked at patients with ectasia and normal corneas, they found that about 6% of his population that he saw, just 6% were spherical. Only 6%. Whereas really 40 plus 25% had asymmetry, where you would really have to do a quadrant specific or a free-form design. I mean, if you think about all the fit sets we have, most of them are toric, symmetrically toric. And if we wanted to fit a patient perfectly, that only would satisfy about 29% of the population based off of his, patient base that he reviewed. So this is saying more of the same. Only 6% of patients would do well in a spherical landing zone, about a quarter in a toric landing zone, and then the others where we really would need to do a quadrant specific or more custom design. Axial length, it's incredible, the accuracy of the axial length scans. That's very important when we're doing myopia management with patients. And then we can use our subtractive map here to really tell the centration of our orthokeratology lens and how even of a distribution we have with that reverse curve. So all that to say is, I posted about a month ago, if there was a fire in my building, first thing that I would grab is my Pentacam AXL Wave. Then I would run. And I'm not alone in this. I had lots of fun comments that were like, heck yeah, I agree. My favorite was Susan Resnick's, where she was like, my Pentacam and my espresso machine. So really some technology that once you have, you just will look back and think, how the heck did I practice before I had this? So thank you so much for having me tonight. This is my email if you would like to reach out for questions for those of you that are not live, and we'll go ahead and take questions now.
Perfect. Thank you so much for that wonderful presentation. I really enjoyed getting to kind of listen to it and pick up some pearls, just like the importance of all of the doctors in your area and just how important those referrals are to the health of your practice. On the note of questions, if you did happen to miss anything tonight, you stepped away from for a moment, your internet went out, what have you. We are recording, and you will be able to watch this on YouTube later, and you will receive a recording to your email. Next, we are still accepting questions. So if you have any questions, please go ahead and submit those now. Alrighty, so first off, you mentioned that you don't accept insurance in your practice. Is that both vision insurance and medical insurance, or just vision insurance?
That's correct. I do not accept any vision or medical insurance.
Great. And so how do you handle that conversation with patients who want to use their insurance in your practice?
Comes up every day. We have patients say, well, I have insurance. Why do you not accept insurance? My virtual assistant is trained on these to have these conversations. And we say, we're very different from practices that you've been to before, in that you're going to be with the doctor the entirety of your exam. And we have the best technology that's in the country that really only a few practices in the country have. And this allows you to have basically a 3D printed lens that's exactly made for your eye. So you'll receive a more custom lens than you've ever had before, and you're going to have one-on-one personal care with the doctor. So we will also provide you with the codes that we use at your visit to be able to submit for out-of-network contribution towards your exam, and a letter of medical necessity. I provide all of that paperwork to patients with a stamped envelope. And then they just mail it off to their insurance company. And at that point, it's between them and their insurance company. And then we also offer, we accept care credit and FSA, HSA. Then we have offered like in-house financing. That's something that I wouldn't say experimenting with it. I have about 60 patients on it right now, like a monthly subscription type plan. I don't call it that, but it breaks down the large sum into monthly sums or monthly payments. Then those monthly payments are ongoing year 2 and on. So those are some of the things that we do to really help patients that have financial concerns. But the last thing that I'll say about that is, when patients know that this is your specialty and you are the expert in the area on this, a lot of them are absolutely willing to pay for it.
Thank you for that insight. So you mentioned, about 65% based on, or 65, 67-ish% based on that one study, of lenses require either a quadrant specific or just a totally asymmetric freeform design. How much time do you think the CSP saves you on average per lens?
Oh, so much time. Mostly, so I see patients that are the worst of the worst, typically because they're referred to my office after failed scleral lens fits. And I would say for my easy patients, this kind of simple cones, I'm oftentimes 2 and done, if not 1 and done. Usually I just have to make like a small prescription change. And then for like my really complicated patients, I'm really needing to do like 3, at most 4 redesigns. The ones that take a little bit more are those that I'm doing like multifocal toric optics in a scleral lens. So it saves me an incredible amount of chair time starting off with a lens that's already very well aligned to their eye.
Absolutely. Speaking of lenses that just require absolute precision, do you fit any sclerals that correct higher order aberrations?
I really would love to have that technology. I don't have the HOA technology yet, but we do have, we'll do lenses in office that have eccentricity built in to try to help with, coma. Of course, that isn't customized to patients, but I will definitely be having that hopefully soon.
That's really exciting. How often are you putting a diagnostic like that or a trial lens fitting set on the eye?
I, you know, there's different philosophies on this, and I'm of the philosophy of that I do it every time. Um, to more so from a patient experience. And some doctors will tell you, well, I would love to have, I want their experience to be when they get their first custom lens with their prescription in it. And I agree with that too. But some patients have no idea how well they'll see in a scleral. So I preface it by saying, this lens probably isn't going to feel very comfortable, but know that this is not how your lens is going to feel when you get it, but this is how you will see. So I'll put a diagnostic lens, do an over refraction, and have them walk around, with trial lenses to see their world. And that is what gets people really excited about these lenses. Um,
Absolutely.
yeah. So there was one other thing that I was going to say. Oh, then also having the CSP information. I can usually look at that and know what diagnostic lens I can select to make them feel the most comfortable in a lens without having to spend a lot of time on the uh,
So,
diagnostic lens fitting
so it,
itself.
gotcha. It speeds up that process.
Exactly.
Perfect. How many patients do you end up seeing every day or each week?
Yeah, that's a great question. It varies. Um, on average, I see about 9 patients a day. Uh, New consults, it varies. Like I had 4 today, I had 5 yesterday. So I'd say maybe like 15, 10 to 15 new patients on average. It's been crazy with new patients lately, so it just varies based off time. But on
Okay.
average, I see about 9 patients a day.
Congratulations on that excellent growth. And about how much time do you spend on average per patient?
That also varies based off of their history. So my VA is trained that if they are existing to a scleral lens, they'll get a little bit shorter of an exam. But if they are new, then they'll get closer to a 2 hour exam, 2 hour consult.
Wonderful. Thank you. I guess the final question that I have for you this evening, in addition to contact lens fitting with the Pentacam AXL Wave, how else are you using it to help with your kind of return on investment? It's an expensive piece of equipment, we'll be, ready to admit.
Yeah. So it in the beginning, it saved me a lot of money because I didn't have to buy, individual pieces of equipment. So for cold starts like mine, it was a no-brainer. But for those folks that already have like a AR and all those things, it's something to consider. This is a cost, and I have an AR or whatever. So a big one is chair time. Um, Especially if you accept insurance, there gets to a point of where you're paying to see that patient, depending on what your chair time is what your reimbursement is. And it's very easy to vault over the cornea, but what's not easy are those edges. And I find that the majority of my chair time in the past was really getting those edges perfected. So chair time in itself pays for itself. But other things like I'll have doctors refer to me for cross-linking evaluations, and those are patients that I wouldn't normally see. But yeah, I think chair time is the biggest thing for me in my practice.
That makes perfect sense. That is the end of our presentation tonight. Before we wrap up, I just wanted to say thank you so much, Dr. Ariel Cerenzie. I really enjoyed your presentation tonight and I learned a ton. And I wanted to thank each and every one of you that attended tonight for your rapt attention and all of the questions that you asked tonight. Any final words, Dr. Cerenzie?
I thank you guys so much for tuning in, and thank you, Carver, for hosting the webinar tonight. And I hope everyone has a wonderful rest of their night and week.
Perfect. Good night, everyone.
Good night. Thank you.